This is the fourth recording in the Patient Healthcare and Intro to Radiography, Chapter 10, pages 173 to 186. Personal care. Concerns of patients. Uncertainty about the upcoming procedure, fear of possible diagnosis, and concern about the effect of illness on family members can cause varying reactions in patients. Sometimes these concerns are expressed as anger and demonstrated as inappropriate speech or rude behavior towards personnel. Other expressions of anxiety may include a need to talk constantly or conversely become quiet and withdrawn. You may observe fidgeting or other nervous mannerisms. Anxiety can also be caused by a concern over modesty, especially when emesis, catheterization, or urinary procedures are expected. Reassuring patients can by providing ample covers an explanation of the procedure and a matter-of-fact attitude. Your presence is comforting to the anxious patient. Touch patients reassuringly and tell them what to expect. Let them know that you have to leave when you leave the area and what you can expect. Escort ambulatory patients to the bathroom and back to their waiting area. It can be very distressing if patients if they must go wander about the hospital gown in a hospital gown, wondering where to go. Procedure trying to remain near the patient if possible. Postpone your lunch or break until the procedure is complete. If you must leave and have another radiographer take your place, introduce your replacement and excuse yourself rather than simply vanishing. If patients must wait in an x-ray room or dressing room, let them know that you are within hearing distance and that they may call you for any help. A call button is available in most patient bathrooms. Show patients how to use it and reassure them that someone will assist them promptly if they call. Physical discomforts adds tension as well. Remember that most patients will find it hard to remain still on a hard surface during a long procedure. This is especially difficult for a thin patient or an elderly person with kyphosis, convex curvature of the upper back. Lying flat on the table may cause obese patients and others with cardiac or respiratory impairment to have difficulty breathing. As you move briskly around the room, the temperature may seem warm enough to you, but to patients who are inactive and ill often feel chilly. Note skin temperature when you touch the patient and inquire whether a warm blanket is needed. Tuck all blankets around the patient to provide both additional warmth and a sense of security. If the patient is coughing or sneezing, offer tissues and position a waste container within reach for their disposal. See Figure 10-1 on page 173. When responding to the physical needs of patients, be alert to the need for preventing the spread of infection and wear gloves whenever the potential for contaminating your hands. If dentures must be removed, place them in a safe and visible location in a suitable disposable container. When you return the dentures, rinse them for the patient or direct the patient to a sink, as dentures slide in much more easily when wet. Glasses and hearing aids also require responsible care. These items are essential for daily living and are difficult and expensive to replace or repair. A plastic box with a lid labeled with the patient's information is a useful container for these items. Choose a safe location in view of the patient. Use the same place consistently and point out the location to the patient. This is especially important for outpatients who have not been provided with a locker to secure valuables such as wallets or a wallet. Physiological needs. Water. Medications or anxiety can cause dry mouth. If an inpatient requests water, first check with the chart and note whether oral fluids are permitted. Many patients receiving intravenous therapy are not allowed anything by mouth. The abbreviation for this order is NPO, for the Latin nil per os, meaning nothing by mouth. This means no food or liquid, not even ice chips or small sips of water, until the physician orders otherwise. Often a damp oral sponge will help alleviate a dry mouth. If the patient cannot sip and water is permitted, offer it with a straw. Remember to record the amount taken in the chart. Elimination. The urgent need to avoid can be very bothersome to a patient. A full bladder may cause discomfort, irritability, and difficulty remaining still during the procedure. When this is needed, it is ignored. And debilitated or feeble patient may experience incontinence, the involuntary loss of bladder and bowel control, and can cause acute embarrassment for the patient and cleanup problem for the radiographer. Be especially sensitive to the need for a urinal, bedpan, or bathroom facility when procedures are prolonged. If the procedure is likely to take a considerable amount of time, you might point this out and ask if the patient would like to visit the bathroom before getting onto the table. When a urine specimen is needed, provide the proper container, cleaning supplies, and instructions for obtaining a clean catch midstream specimen. These instructions are included in Appendix H and often printed on signs and posted in patient restrooms. When a patient needs to defecate or urinate and unable to walk or be taken to the bathroom in a wheelchair, a bedpan or urinal is needed. Placing a patient on the bedpan or offering the urinal is not a complex task. If you are unfamiliar with this procedure, the chief obstacle is to overcome the embarrassment. Learn the location of the equipment needed in the practice these procedures before you need to use them in a clinical situation. There are two types of bedpans. A fracture bedpan, see figure 10-2 on page 174, has a flat lip in the front that makes it easy to slide under the patient with whom the problem is lifting the pelvis for bedpan placement, such as a patient in a cast. The regular bedpan is somewhat larger and deeper and has a rounded lip designed to support the buttocks. Single-use bedpans and urinals made of disposable material are now available in many emergency departments and short-stay hospital departments. Special disposal units accept both container and contents, which minimize handling. To assist a patient with a bedpan, assemble the supplies you will need, don non-sterile gloves, and follow the procedures outlined in box 10-1 on page 175. Be sure the patient is adequately covered for privacy. When a female patient is placed on a bedpan, the upper torso needs to be slightly elevated to prevent urine from running down the upper back. When a patient has restricted mobility, two people may need to help to assist the patient onto the bedpan. If the patient is lying onto the back X-ray table, one person should stand on each side of the table to prevent the patient from falling. Patients may find it difficult to use the bedpan if they feel they are being watched, so remain out of the line of sight if possible while staying close enough to maintain safety requirements. When the patient has finished, you will have to assist with wiping. Wear gloves and have toilet tissue, a wet washcloth, or a dry towel conveniently placed. Assist the patient in lifting the hips or rolling away from you onto one side while you steady and remove the pan. Place it safely aside and help the patient by wiping from front to back with paper first and then with a wet washcloth before drying. After the patient is offer the patient a disposable moist towelette or a clean wet cloth or towel to clean the hands. Male patients may use a urinal. If he is unable to use it himself, don non-sterile gloves and spread the patient's legs. Lift the sheet with one and slide the penis into the urinal with the other. It may be advisable to hold the urinal in position until the patient is finished. Check the chart before emptying the bedpan or urinals to see if the patient is to have a urine or feces specimen collected, or if intake and output, I and O, need to be measured and recorded. The nursing staff should call this to your attention. Make sure the correct container is available and ask the nursing staff for instructions if you are unfamiliar with the procedure. The exact procedure for a specimen collect will vary somewhat with the institution. Patients sometimes require a quantitative urine test that demand that all specimens be saved. Failure to comply may invalidate the entire 24-hour collection. If such a test is needed, a special container should be provided. If no test required, specimens are ordered. Measure and discard the urine and record the amount. Most urinals are marked in milliliters for easy measurement, but urine in a bedpan must be emptied into a graduated cylinder for measurement. If stool is present, observe it for obvious blood or diarrhea and record any such observations. Empty the bedpan or urinal carefully into the hopper or toilet to avoid splashing. Rinse all containers and place them in the correct location for disposal or sterilization. Remember to perform hand hygiene after removing your gloves. Some patients will have a urinary catheter or tube. These tubes are inserted through the urethra of the bladder, allowing urine to be continuously emptied into a attached collection bag. The most common is called a Foley catheter. It has a small balloon at the tip that can be inflated with water to hold the tip securely within the bladder. And when these patients are transferred from the wheelchair to a stretcher or the radiography table, hold the urine collection bag below the level of the patient's bladder to prevent urine running back into the tube from being siphoned back into the bladder, causing discomfort and potentially allowing bacteria access to the bladder. If the bag is full, empty it, measure the urine if necessary. Some collection bags consist of a rigid measuring container within a flexible plastic reservoir. Urine flows first into the graduated section, tipping the unit empties the measured urine into the reservoir. Most collection bags have a drainage outlet at the bottom. Wearing non-sterile gloves, open the clamp and allow the bag to empty into a suitable waste container or a graduated pitcher. See Figure 10-3 on page 175. Reclose the clamp. Because most patients with urinary catheters require input and output measurements, be sure to record the amount. Colostomy care. Occasionally you will encounter a patient who has a colostomy or ileostomy, where a surgically removed passage from the large or small bowel through the abdominal wall that will terminate in the external opening, called a stoma. A temporary colostomy may be performed to rest the bowel and allow it to heal after a surgery, massive trauma, infection, or chronic disease. After the bowel is healed, the healthy portions are reconnected via anastomus and the temporary opening is closed. A permanent colostomy is one in which the diseased portion of the bowel is removed. Patients with colostomies or ileostomies wear an external bag to collect material and may be extremely sensitive about wearing this apparatus. Patients with recent colostomy may find the alterations in body image difficult to accept. An express of revulsion on your part may be perceived as disgust and rejection. If you have never seen a colostomy, your first encounter should be as an assistant to an experienced radiographer. More detailed information about colostomies and their care should be found on Chapter 17. Patients almost invariably carry supplies with them when outpatients are scheduled for procedures that require removing colostomy bag. Remind them to bring their own supplies because brands of colostomy bags vary in size and shape of opening. If it is necessary to empty the colostomy bag, the patient may prefer to complete this procedure in private. You may need to provide a sealable bag for the use of supplies and facilities for hand washing. If you must empty the bag, don gloves and empty the bag into the toilet. If the empty bag is disposable, seal it in a plastic bag and place it in the container for contaminated waste disposal. Because some patients rely on reusable colostomy bags, check before you dispose of the used bag. If the patient does not have a clean bag, rinse it out with cold water and allow the patient to reattach it. However, empty the reusable bag, rinse it, seal it in a plastic bag, and return it to the patient. Be sure to perform hand hygiene after removing your gloves. of course. If the patient is unable to perform his or her own colostomy care, you may need to apply and assist with the application of a fresh colostomy bag. Procedure 10-1 on page 177 demonstrates the basic procedure when performed by a competent patient. When assisting the patient, be sure to wear protective gloves. The unit includes two principal parts. A base portion surrounds the stoma and attaches to the body by means of a special adhesive. It protects the skin surrounding the stoma and has a rigid flange that forms a secure connection to the second part of the system, the disposable pouch. Products vary to meet individual needs of patients and manufacturer standards. Product inserts contain complete application instruction. Sanitary supplies. Occasionally, a patient may be required a sanitary napkin, so be sure that you know where these are kept. If a soiled napkin is to be removed, direct the patient to the bathroom or place a paper bag within reach. Place the bag with the soiled napkin in the appropriate container. The patient who suffers from poor urinary control or stress intestines may use urinary pads to protect their clothes. These supplies are similar to sanitary napkins, are usually stored in the same location, and are disposed of in a similar manner. If a replacement is necessary, urinary pads are preferable, but a sanitary napkin may serve as a temporary substitute. Positioning for safety and comfort. Body positions. Common body positions have names. It is easier to communicate with other members of the healthcare team and follow physician's orders if you are familiar with these terms. See figure 10-4 on page 178. The term recumbent refers to any position within the patient lying down supine. See figure 10-4 subsection A defines the position in which a patient is lying on his or her back. This is the usual position of a stretcher transfer and is often common radiographic position. When lying face down, the patient is said to be prone. See figure 10-4 Bravo. Lateral recumbent position denotes that the patient is lying on one side. This term may be modified by adding left or right to indicate which side is in contact with the bed or table. This patient in the figure 10-4 Charlie is in the left lateral recumbent position. The Sims position, see figure 10-4 Delta, in a comfortable position that is sometimes used for rectal examination and for taking a rectal temperature. It is the best position for enema administration. Ballard's position, see figure 10-4 Echo, is a modification of the supine position in which the patient's upper body is elevated. The semi-Fowler's position, see figure 10-4 Foxtrot, is a modification of the Fowler's position in which the upper body is only partially elevated. In the Trendelenburg position, see figure 10-4 Golf, the patient head is lower than the feet. Usually the table is tilted approximately 15 degrees. This position is used during some radiographic and fluoroscopy procedures and is helpful in treating patients who suffer from shock. The knee-chest position, see figure 10-4 Hotel, and the lithotomy position, see figure 10-4 India, are not commonly used by radiographers, but are standard positions used by physicians and nurses to do in diagnostic examinations and therapeutic procedures. Support and padding. When lying on a hard surface, such as a radiographic table, patients are more comfortable with radiolucent sponges or cushions strategically placed that support sets of radiolucent sets of radiolucent sponges in various shapes and sizes are available in the radiology department for this purpose. See figure 10-5 found on page 179. If a cushion or pillow under the head is not to be a hindrance with the examination, it could enable the patient to see what is occurring and thus help relieve apprehension. Elevate the patient's head so as to relieve. Also, to relieve neck strain, allows easier breathing and helps avoid the uncomfortable sensation that the head is lower than the feet. A bolster under the knees of a supine patient relieves lumbar sacral just by straightening lordosis, the lordotic or concave lumbar curve. See figure 10-6 on page 179. This is especially comforting to a patient with kyphosis, those with a pronounced concave curvature of the upper back. To those with arthritis, and most of the elderly patients, bolsters are essential for patients with spine injuries and those who have recently undergone spinal or abdominal surgery. Patients with abdominal pain should have the head elevated and a bolster placed under the knee to relieve pain on the abdomen. The measures used to promote comfort are frequently the same interventions designed to prevent complications. When the body is supine, the weight of the abdomen contents pushes on the diaphragm up into the thoracic cavity, making it more difficult to make a deep breath. This is no problem for most of us, but if a patient becomes short of breath when supine, you must help them sit up immediately. The terms of difficulty breathing when laying down is orthopnea. This condition may be caused by asthma, lung disease, or heart condition. Patients who are nauseated also need to have their heads elevated because this position helps control nausea and prevents aspiration on emesis if the patient vomits. Patients who have become nauseated and cannot be assisted into the valgus position should be rolled onto the lateral recumbent position. Padding placed under the body prominences, such as the sacrum, heels, and the mid-thoracic curvatures, is often essential for comfort on hard surface. When patients are reasonably comfortable, they are better able to maintain the position needed for an effective examination. If a patient will be in one position on the x-ray table for longer than 10 minutes, a full-size radiolucent pad should be used. This is an important consideration for patients undergoing extended studies such as a small bath series or excretory urograms. Older or debilitated patients can develop ulcerated areas over predominant bony structures when pressure is exerted for even a short period of time. These lesions are referred to as decubitus ulcers or bed sores and are discussed further in the following section on the complication for elderly and debilitated patients. Empathy for patients is enhanced by experiencing what they feel during a radiographic examination. Practice positioning on your classmates until positioning and reassuring comfort are part of the same action. Considerations for elderly and debilitated patients. Age does not automatically determine a person's health status. Many old people are quite active and healthy. The conditions of an elderly patient may fall anywhere along a spectrum that ranges from vibrantly healthy and alert to seriously confused or debilitated. Normally, healthy elderly patients will usually display certain characteristics that are typical of advanced age. For example, one attribute of aging is the tendency to proceed at one's own pace, both mentally and physically. Older patients do not respond well to feeling pushed or hurried, so take your time, assist them as needed, and provide a safe, uncluttered environment. It is also accompanied by physical changes in the skin and the circulatory system. A decreased tolerance to changes in the temperature is common, so you may need to provide extra blankets during the examination. Loss of these sense of balance, and lack of depth perception may increase the likelihood of falls, so you need to assist the elderly during ambulation. Do not leave them unattended on the x-ray table if your assessment leads you to the concern about falls. Precautions must be taken to protect their skin while moving from and positioning older patients. Roughly handling or sliding against the table may cause injury to the skin or elderly or debilitated patients. A subcutaneous fat layer cushion in the skin of young persons cushions the skin of young persons. This underlying padding decreases with age and may be non-existent in the elderly. When the subcutaneous fat layer is lost, any shearing pressure can cause the skin to tear and bleed. The skin of the feet and legs is especially delicate in patients whose circulation is compromised. You must pay attention to avoid bumping the skin. Do not wear jewelry on hands or wrists that could cause injury to a patient during the process of moving or positioning. Even minor contusions or abrasions may increase the likelihood of decubitus ulcer formation. The cause of decubitus ulcer is simple to understand and important to remember. Pressure on a limited area of tissue inhibits circulation, depriving the cells of oxygen and nutrition. Cells in the middle of the area are affected first. If the pressure is not retrieved and circulation restored within a few minutes, the cells in the central area die and an ulcer is formed. Weak or debilitated patients may be in a poor nutritional status and have impaired circulation. In such cases, the ulcers do not heal well and may even require skin grafting. A circle or donut ring, an ineffective type of padding, a circle donut ring is an ineffective type of padding used. Although it does prevent pressure on a specific bony premise, it restricts the circulation on the central area by placing pressure all around it. It is preferable to distribute the weight over as large an area as possible. If a debilitated patient must be left on the table or on a stretcher for an extended time, the radiographer should assist the patient in changing positions periodically to relieve pressure and maintain circulation. It is also important to keep patient clean and dry. Patients who perspire heavily or are incontinent of urine or feces may develop skin irritations that predispose them to ulcer formation. Restraints and immobilization. Restraints are used to restrict patient movement and ensure safety, whereas immobilization methods prevent undesired movement during imaging procedures. Patients who are active and disoriented may require physical restraints. These may consist of wrist or ankle bands or a vest that's straps tied to the bed or stretcher. Restraints are used to prevent patients from injuring themselves or from disengaging therapeutic devices such as intravenous or oxygen lines. The application of these physical restraints on an adult patient requires physician's order. Although restraints may be annoying to patients, they are neither painful nor harmful when properly used. Restraints are usually fitted before the patient comes to the radiology department. The same restraints should be used by nursing services may be employed by the radiographer. If you remove restraints for transport or to meet the requirements of an imaging procedure, be sure to replace them as soon as possible. Safety straps or side rails must be constantly on beds and stretchers to prevent falls when patients are asleep, weak, disoriented, or sedated. A physician's order is not needed to apply these types of safety devices. Safety straps or compression bands may be used on X-ray tables during waiting periods as a precaution against falling. Patients whose motion is restricted by safety devices must be monitored carefully. Never leave a patient unattended who is unable to change the position. Difficulty breathing or the need to cough or vomit may require an immediate change from position. The patient's inability to respond to this need may pose a serious hazard if you remain with the patient. If you leave the room, another qualified person must remain with the patient. When patients are coherent and comprehensive and neither sedated nor in distress, deciding whether to leave them alone for a brief period must be based on the existing hospital or department the policy. Immobilization. Immobilization refers to the use of various devices to keep patients from moving during imaging procedures. These applications are not categorized as restraints and do not require a physician's order. Several methods may be used to aid in the immobilization of adults who have difficulty remaining still. When tremors complicate the procedure, support the patient as comfortably as possible. Place a compression band across the abdomen or knee or a sandbag across the extremity proximal to the area of interest to provide stabilization during the radiography. If tremors can be controlled in the hand and the arms, this is often stills tremors throughout the body. One way to do so when the patient is supine is to place the hands and wrists under the buttocks if this position will not interfere with the examination. Although it is preferable to win the confidence of small children and have them submit willingly to examination, occasionally you must immobilize children for their safety to meet the technical procedure requirements. The weight of a sandbag or a lead protective device can be used to help maintain position. Sheets of translucent plastic are useful for holding a tiny extremity in position against an image receptor or IR. Tape can also be used to maintain a position. Tape can be used to hold a tiny finger in position and on an IR or to strap a small patient's hip to maintain a supine position on the X-ray table. Be certain that cloth or a tissue protects the skin from the adhesive surface of the tape, or twist the tape so that the non-adhesive side is against the patient. A stocking net can be used to immobilize the legs or applied to keep the patient's arms above the head. See Figure 10-7 on page 181. Figure 10-8 found on page 182 demonstrates the mummy wrap method used to immobilize an infant or a small child. Fold down on the top edge of the small sheet or lightweight blanket to form an inverted triangle. Place the child supine with shoulders just below the fold. Put one point of the sheet across one arm, tuck it behind the back, and pull it through the opposite side. Wrap this same point across the child's chest and around the second arm and tuck it and circulate under the patient. Then grab the second point and wrap it across the chest and tuck it behind the back. Immobilization equipment such as circumcision boards and other specialty devices is commercially available to help immobilize children simply and effectively. See figure 9 or 10-9 on page 183 shows these two devices, the papoose board and a radiolucent board with Velcro wraps and straps available in several sizes, and the octostrap positioning device that rotates to one place the patient at any of 8 positions. The Pigostat infant chair, see figure 10-10 on page 183, holds infant and toddlers firmly in the correct upright position for chest radiography. This device incorporates a cassette holder and gonad shield. Observations of signs of abuse. Child abuse. Whenever a child is brought for treatment, physicians and other healthcare professionals should be alert for indications of battered child syndrome or characteristics of physical abuse, also referred to as non-accidental trauma or NAT. The incidence of a child abuse is remarkably high. The total abuse rate is estimated to be as high as 1 case per every 10 children. Wow, that's high. The majority of these cases are attributed are attributable to negligent, but these statistics also include sexual, emotional, and physical abuse, with considerable overlap between the categories. Approximately 1/4 of abused children suffer physical abuse or battering. Any of these signs should raise concern about this possibility. Multiple injuries. Evidence of chronic repeated injuries with no other explanation. Injuries that are not consistent with the patient's report of trauma. Failure to seek prompt treatment for serious injury. Bruise marks shaped like hands, fingers, or objects, such as a belt. Specific patterns of scalding, such seen when a child is immersed in hot water. Burns from an electrical stove, radiator, heater, or other hot object on a child's hand or buttocks. Cigarette burns on exposed areas or the genitals. Black eyes in an infant. Human bite marks, lash marks, choke marks around the neck. Circular marks around wrists or ankles, twisting. Separated skull sutures and bulging fontanelle in the infant. Unexplained unconsciousness in an infant. The last two items on this list are evidence of possible brain injury. Because of the difference in size and strength between adult and children, the abused child can be severely injured or killed unintentionally. Shaking an infant, for example, can cause bleeding over the brain, subdural hematoma, which can cause permanent brain damage or death. This condition is called shaken baby syndrome. Figure 10-11 on page 185 illustrates a classic case of battering child syndrome. The radiographs of the lower leg show the periosteal reaction from repeated bruising to the bone. This type of injury is sometimes referred to as classic metaspheral lesion, or CML. The abuse was subjected. A skeletal survey was done. That is, a radiograph was taken of the skull, extremities, and thorax. The chest and ribs study showed highly suspicious fractures of 5 ribs, which have partially healed. 4 months after the skeletal survey, the child was again treated, this time for a fracture of the forearm. This patient stated that the injury had occurred on the previous day, but the radiograph showed evidence of healing at a fracture site, indicating that the injury had been present longer. CML was also noted at the wrist. In this case, the diagnosis of child syndrome was undeniable. Elder abuse. Each year, hundreds of thousands of older persons are abused, neglected, and exploited. Many victims are people who are frail, vulnerable, and cannot help themselves. They must depend on others to meet their basic needs. Abusers of older adults are both women and men, and many are caregivers, family members, and friends, or trusted elders. In general, elder abuse is a term referring to any knowing, intentional, or negligent act by a caregiver or any other person that can cause harm or serious risk of harm to a vulnerable adult. Legislatures have passed various forms of elder abuse prevention. As with children, physical abuse in older adults may be termed NAT. Laws and definitions of terms vary considerably from one state to another, but broadly defined, abuse may include any of the following. Physical abuse, inflicting physical pain or injury on a senior, for example, slapping, bruising, or restraining by physical or chemical means. Sexual abuse, non-consensual sexual contact on any kind, neglect, the failure by those responsible to provide food, shelter, health care, and protection for a vulnerable elder. Exploitation, the illegal taking, misuse, and concealment of funds, property, or assets of a senior for someone else's benefit. Emotional abuse, inflicting mental pain, anguish, or distress on an elder person through verbal or nonverbal acts. Example, humiliating, intimidating, or threatening a person. Abandonment, the desertion of a vulnerable elder by anyone who has assumed the responsibility for care or custody of that person. Self-neglect, the failure of a person to perform essential self-care tasks, threatening his or her health or safety. As you have learned earlier in this chapter, elders tend to bruise easily. Their skin is easily damaged, and if there is dementia, the reports may be confused or inaccurate. For some reason, it may be difficult to determine whether injuries are evidence of abuse or whether an individual's complaint or reports are true. Although one sign does not necessarily indicate abuse, there are some telltale signs that there is a problem as follows. Bruises, pressure marks, broken bones, abrasions, and burns may be indications of physical abuse, neglect, or mistreatment. Unexplained withdrawal from normal activities, a sudden change in alertness, and unusual depression may be indicators of emotional abuse. Bruises around the breast or genital area can occur from sexual abuse. Sudden changes in financial situations may be a result of exploitation. Decubitus ulcers, unintended medical needs, poor hygiene, and unusual weight loss are indicators of possible neglect. Behaviors such as belittling, threats, and other uses of power and control by spouses or adult children are indications of verbal or emotional abuse. Strained or tense relationships and frequent arguments between the caregiver and elder are also a sign. Although your contact with patients is often brief and not ongoing, you may be in a position to recognize signs of physical abuse or neglect. When you do, notify your supervisor while the patient is still in the imaging department. This concludes the Chapter 10 of the PCR.